I can't believe we disagreed on so many.
Are you really picking that block?
Really? That's the block you picked?
You're only giving me 5? You know that's another show.
Let's back up here. What are you saying exactly?
Not for old geezers. You know I'm right.
The gloves are coming off. Whose block list tops them all? Hello and welcome to Walk Around the Block. I'm Jeff.
I'm Stuart.
And today we're going to be talking about the 5 blocks that you must know to get out in the real world and do regional anesthesia. It's a hard question, right?
Only 5.
Only 5. If you're a resident, you're getting out there and you're not going to do a fellowship, but you want to incorporate some regional anesthesia into your practice. You can't know all 40 blocks or 50 blocks. So what do you choose?
Well, yeah, in America, the ACGME says you've only got to do 40 blocks.
Right.
So if you want to do 5, that really is...
And 20 of those are ankle blocks.
So 5 should probably be enough. Although most residency programs will do more than that, and certainly at Duke and at University of North Carolina we do a lot more. But still,
yeah,
getting good at 5, that's a great start.
Yeah.
Okay.
So what are the 5? I mean, let's go back and forth and figure out what.
Okay.
And stick around to the end because you'll see if we agree on our lists here.
Yeah, we've made our lists and we might not agree on everything.
We'll see.
So, should I go first?
Go ahead.
Okay, so let's stick to shoulder. And I'm going to throw the curveball, and rather than say interscaling, I'm going to say superior trunk block.
Okay. All right. Why?
Well, I've ended up using this instead of interscaling to try and avoid some of the side effects, reduce the breathlessness by going a little bit lower. And I think this is often easier to scan a little bit lower for beginners than it is higher up.
All right. So you reckon that it spares the phrenic nerve a bit more than...
A little bit lower down, maybe don't use... I
Yeah.
mean, the bad old days of using a nerve stimulator, I'd put in 35 cc's, put the needle in.
Minimum.
Don't move, and then put in 35 cc's, and you'd hope it would work. Now using much lower volumes and going a little bit more distal, I think...
Yeah. You're sparing it. So.
Yeah.
Yeah.
What about you?
All right. Well, I'm a traditionalist here. I'm going to say interscaling. I think that for shoulder surgery on the clavicle, nothing beats a solid interscaling. And I just love the image that you get and the elegance of the whole thing. And then as I'm pulling out, I can do a little cervical plexus block at the same time and get that skin.
Get above the fascia and
yeah.
get that. And that's really important for the skin. I think the disadvantage of what I've talked about is communicating that to, if you're a trainee, to your attendee, hey, I want to do a superior trunk block. Some people are going to go, what?
Yeah.
But so I think, okay. So right off the bat, slight difference. We're probably talking a difference of, a centimetre and a half between one or the other. But okay. What about for upper limb cases?
Upper limb, gotta go infraclavicular. It is my favorite block above the waist. And the reason is it covers everything from the acromion on down, and it's one and done. All you got to do is put that needle just south of the artery at the 6 o'clock position, and you're done. You don't have to mess around getting different chords, different divisions, and so I think it accommodates a catheter really well. So if a lot of our upper limb trauma cases, we'll put infraclavicular catheters in, and it's easy to maintain and sticks around for 7 to 10 days.
So I'm going to disagree slightly. I'm going to go for supraclav, which I love. If you use mepivacaine, bicarbon epi, by the time you pull the needle out, the arm is completely gone.
A spinal of the arm.
I love. Yeah, I know that's a goodie and an oldie, but it really does set up quickly.
Yeah.
I also like the ability that I can see after the local's in. I can see the inferior trunk, the middle trunk, the superior trunk. And if I'm going to leave a catheter, if the surgery's in the thumb side, I'm going to place it between the upper and middle trunk. Or if it's the hypothenar eminence and the ulnar side, the little finger, I'll place it between the lower trunk and the middle trunk. And my catheters are very successful there and seem to stay in place. So I think at the end of the day, though, most papers would say, it doesn't matter which one you do, you're equally successful in both.
It's the
But-
same block.
But
Yeah.
yeah. But I like to think that mine is better.
Yeah. In Stu's world.
Inside my head, inside the tinfoil. Okay, so
All right. How about we go to lower limb?
okay, and if we're going to pick five, I am just going to go for femoral. I think I can use this for hip, and I can use it for the knee. It's not ideal for the hip. I'd probably prefer to do a suprainguinal fascia iliaca, and I was teaching that in a systematic approach, teaching that to a couple of residents yesterday, and there was a lot of head scratching as you do that. I think the femoral, the arteries there, is pulsatile, it's easy to see. I can use it for above knee amputations, I can use it for knee replacements, you know, and even use it for further down the leg, for medial side of an ankle surgery. It's not ideal, but if I've just got to teach 5 blocks, I think that's going to be in the must-have list.
Well, listen, I'm going to agree with you here.
For the first time!
Yeah, and I think you're underselling the femoral. I mean, a little bit. I know we're being apologists here in terms of what it offers for knee surgery, and everyone's gone to adductors, and we have, to be fair, for the muscle sparing part. But I love a good femoral block, and for amputations, we still do femoral catheters for hip fractures in the emergency department. And your teaching comment is a good one, because it's really, I think it's easy to teach a femoral block to every CA3 resident that we have, and therefore we have a robust and reliable and consistent service. We've thought about teaching the fascia iliaca to our residents, but I'm not sure we could achieve the same consistency and reliability.
And yeah, the hip fracture stuff, when we have at night a mixture of faculty going down,
Right.
we just went to the femoral.
Yeah.
It's just easier to teach. It's the one that everybody knows. And I
Seen
think, and to be honest, you and I have had this discussion. When the day comes that we need our knee replacements,
Femoral catheter, baby.
femoral catheter. I want maximum pain relief. I don't care about the ambulation. I'll get there eventually, but please, maximum pain relief at first.
Wheel me around.
Yeah. Okay.
Cool. All right. So we agree on that.
Okay.
Yeah.
So the fun part about the lower limb is you get to know
You get 2.
2 injections. It's the best part, Bruce. So twice the fun. But
Yeah.
what are you going to do?
My favorite block, the popliteal sciatic block. And there's just an elegance to this. You know, you see the 2 components, the tibial and the peroneal, coming together. The little plane in between, and the perineural sheath, and when you see that local spread around both, it's just, I know I'm getting very visceral here. I feel like I'm in a cooking show or something, but it's
You're getting in the zone.
I'm in this,
You know what?
but it's just such a dense, good block of everything from the knee on down.
I love the popliteal. This is the second time we agree. I'm going to go for popliteal too. I think if you're trying to teach any more proximal sciatic, if you want to learn 5 blocks, that's just tough. The imaging can be variable no matter how good you are. And so I think the popliteal is excellent. It's not ideal for above knee amputations. We've got a lot of vascular surgery patients, and so that's one time we can use it. But you know, we're using a variant of that for the IPAC, so the anatomy is relevant for that as well. It sets you up for that. It is slow to set up. I call it set it and forget it. You know, we'll be ready in a while. It's not good for first case in the morning. You arrive in bleary-eyed and the nurse has just finished getting the patient set up and it's all go. Popliteal is not good for that, but certainly for catheters, single shots, phenomenal. Yep. Okay.
Tried and true. All right. So we get 2 upper, 2 lower trunk block.
Okay.
1 trunk block?
1 trunk block.
Okay.
Okay.
Let's hear it.
I'm going to be a forward-thinking new and go for ESP.
Ooh.
So, there's a lot of case reports so far and not many randomized controlled trials, but they're starting to come out.
Yeah.
And I think it's, the premise here is 5 blocks teaching beginners.
Yeah.
And so that is why I'm going for ESP here. It's superficial. I hope people can't do too much damage with this. This should be, hopefully, although I've seen people manage to avoid the needle completely and put it a bit too deep. But I'm going to go for, that's what I'm going to ESP. I think I can use it for both lower thoracic segments for the abdomen and upper thoracic segments for the chest.
Yeah, I think from mandible down to
Yeah,
knee,
I
right?
think down to sacrum.
Yeah.
There's actually somebody done it in the sacrum. There's a Turkish group reported in the sacrum.
Undoubtedly, yeah. No, I think there's deservedly a lot of enthusiasm for this block, and I think there's a growing amount of evidence that it does a good job. So, I'm gonna. How am I the traditionalist in this group? But I'm gonna go. I'm gonna say paravertebral, and I know what you're saying. You at home, you're saying, Jeff, how are we going to teach beginners paravertebrals? But I think with ultrasound, it's changed things a bit, right? Like in the old days when I learned, it was hit the transverse process, come back, go in a little more, and hope that you're in the right spot and you're not going to drop a lung. But ultrasound, you're seeing the pleura, you're making careful, slow adjustments down with little bits of saline, and then you're seeing that depression. And even, with the MTP block, you don't even have to go all that far. You can just go right in the middle of the two.
Paravertebral or MTP, what is it?
Okay, paravertebral.
And are they any different? So there's another show.
Yeah.
Okay.
I think
paravertebrals,
at least one.
MTP, ESP. There's at least one show in that. Yeah. So yeah, that's going to come up soon.
Stay tuned for the pro-con on ESP versus PVP.
Oh yes, love that idea.
Yeah.
Love that idea. Okay, so we've got 5. We didn't agree. I'd love to hear what people think.
Yes, send us your idea. Send us your list of 5.
What is your top 5 if you're a beginner? Okay.
Hashtag Fab5 blocks. Send them in to us at walkaroundtheblock@gmail.com.
So, but also, if you're an old hand and you're super experienced, what would your 5 be? If there's no remit of just being a beginner, would you change it? So if you say, I've got 5 to do, and these are the 5 I think are the 5 best, or the 5 easiest to teach, maybe the 5 best, I'd love to hear that too.
This is the desert island scenario, right? If you had, yeah. Excellent. Well, great. Well, join us next time on Walk Around the Block.
See you next time.